Hello, my name is Harris Carmichael, and I'll be assisting you on your tour through Hematology and Oncology for the USMLE Step 1. If we're being totally honest with ourselves, with zero bias whatsoever, Hematology and Oncology is the most important subject in all of medicine. I mean, think about it. What is the function of the kidney? To filter blood. And if it's lucky, it gets to go, hey, we need some more blood over here. The liver goes one step further in importance, making some things for blood, and the spleen is, it's basically a rest stop for red blood cells. Lastly, what is the sole function of the heart? To pump blood. I mean, how important would a cardiologist be without a hematologist? On top of all of this, hematology and oncology has some of the most remarkable diseases that we're going to cover in our studies. So if you're not convinced yet, let me show you what you're missing out on. We're going to start our tour right here in Hematology and Oncology Anatomy with the erythrocyte, or the red blood cell. In order to understand these cells, we should first understand how they came to be erythrocytes. All blood cells are made in a process called hematopoiesis, and they all derive from the same multipotent stem cell. And what does that mean? Well, this means that stem cells can differentiate into multiple cell lines, but importantly, not into other tissues. That is the definition of a multipotent stem cell. These particular multipotent stem cells are called hematopoietic stem cells, and they first divide to replace themselves before they continue on to differentiate. Next, they break into one of two lines of cells, the myeloid and the lymphoid cells. We'll discuss the lymphoid cells later, but for now we'll focus on the myeloid progenitor cell. This is the cell from which the erythrocyte is directly derived, and it's where we'll start today. The entire function of these cells is to facilitate gas exchange between the tissues and the blood. These cells have done everything they can to do this job perfectly. They degrade their nucleus during maturation to make room for more hemoglobin, and are in a biconcave disc shape, which gives dual functionality in that it serves to increase their surface area to volume ratio to facilitate gas exchange, and makes them incredibly pliable and durable, which helps them fit through tiny capillaries. Now, I touched on something very important and high yield in there, and that's that at some point during this process of erythropoiesis, the RBC loses its nucleus, and young RBCs that have just lost their nucleus have a large amount of ribosomal RNA in their cytoplasm that you can stain for. Do you know what this stain is called? It's called a supravital stain. And of course, the most famous supravital stain of them all is methylene blue. Here we have a photo of what these cells would look like after staining. This is important because this is a way we can detect how young an RBC is. These young RBCs are called reticulocytes. And what would an abnormally large amount of reticulocytes tell us? Well, it would be an indicator that the body is making new blood cells, like when you're replacing blood after a hemorrhage or hemolytic anemia. For instance, if the test were to give you a patient with anemia who had a low reticulocyte count and a low reticulocyte index, what would that indicate? Well, it means that the bone marrow can't produce new erythrocytes as quickly, and you should look for an answer that deals with bone marrow malfunction. Conversely, if the reticulocyte count and index were high, then it would be a problem outside of the bone marrow, like blood loss. But you retain the ability to produce erythrocytes at a rapid rate. These are topics we'll get into a little later with anemia, but it's something you're really going to want to pay attention to, as it can point you to the right answer in your questions. Now, I said these erythrocyte cells were important in gas exchange, and the RBC membrane is vital for that. Of note, there's a very important channel called the chloride bicarbonate antiporter, and it is used in the physiologic chloride shift that enables carbon dioxide transport in the blood. This topic will be covered a little more in depth in your respiratory section, but it's a great place for you to connect the anatomy of the RBC membrane with high-yield biochem and physiology that is always super important for your test. Basically, carbon dioxide that is in the plasma diffuses into the cell and is converted to bicarbonate, because bicarbonate's a better storage platform providing the pH buffer for the blood. Bicarbonate is then transported out of the cell and into the plasma via this chloride bicarbonate antiporter in exchange for the chloride ion to keep the charge across the cell membrane equal. Importantly, this reaction can occur in both directions, It occurs in the direction I've drawn here, entering the blood from the tissues, and in the reverse directions in the lungs to expel carbon dioxide. Lastly, here's some additional vocabulary you'll need to know regarding RBC pathology. Low RBC count is called anemia, while high RBC count is called polycythemia. Anisocytosis refers to varying sizes of RBCs, as you can see here. When you're looking at blood smears, you should note that RBCs should be roughly the same size as lymphocytes, so you can see some of the RBCs in this picture are much too small. Poikilocytosis means varying shapes. You can see poikilocytosis in this iron deficiency blood smear. Next we will discuss the thrombocyte, more commonly known as the platelet. Platelets are also in the myeloid lineage, and as we can see here, derived from the megakaryocyte. Platelets take part primarily in clotting, or hemostasis, and this topic will be covered later in the chapter. Platelets are small cytoplasmic fragments that split off from megakaryocytes. There are normally 150 to 450,000 per microliter, and they circulate in the blood for 8 to 10 days. The megakaryocyte is the largest cell in the bone marrow, and has a multilobulated nucleus. The image here of a megakaryocyte is a very accurate depiction, and if you see a bone marrow aspirate on your exam where they identify a cell that is several times larger than any other cell with this crazy looking nucleus, lots of cytoplasm, look for an answer that deals with megakaryocytes or thrombocytes. So why is it that when a patient takes aspirin, they require about 8 to 10 days to fully recover clotting function? Well, that is because aspirin binds irreversibly to the COX enzymes inside the platelets, so then you have to wait for those platelets to die off and be replaced before full function is regained, 8 to 10 days later. The distribution of platelets is also interesting, in that 1/3 of the total platelet pool is typically found in the spleen. This is why patients who have splenomegaly can become thrombocytopenic, or have low circulating platelet counts, because vastly higher fractions of the platelets end up in the spleen. Conversely, asplenic patients, those who have no spleen, or patients with autosplenectomy, like sickle cell patients, you'd expect them to have a thrombocytosis, or an elevated platelet count, since that 1/3 of platelets re-enters the bloodstream. When the endothelial layer of a blood vessel is damaged, platelets are activated and interact with von Willebrand factor and fibrinogen to form a hemostatic plug. After being activated, platelets have two main types of granules that are released. Dense granules, which contain ADP and calcium, and alpha granules, which contain von Willebrand factor and fibrinogen. Thrombocytopenia, or reduced platelet function, can lead to increased bleeding time and characteristic red dots on the skin called petechiae. These can be seen here and are from vessel bleeding. You may also see mucosal bleeds like epistaxis, menorrhagia, and gum bleeds. Platelets also have a number of surface receptors that bind various substances stored in their granules. These types of receptors are the targets of many drug classes, which are designed to inhibit platelet activation. For example, platelets have ADP receptors that bind, you guessed it, ADP. But do you remember from which granule type the ADP comes? ADP is from the dense granule, and drugs like clopidogrel can block the receptor and inhibit platelet activation. Platelets have other important surface receptors, which include GP1B, and this one's not as easy for the substance, it's von Willebrand factor, as well as GP2B3A, which is just fun to say, and binds fibrinogen. These receptors also serve as sites of action for various drugs, and we'll discuss these later in the chapter. Here's a quick flash quiz for us. If the CBC of a patient demonstrates an anemia with a low reticulocyte count and a thrombocytopenia, where is the most likely location of a pathologic process in this patient? Our answer is in the bone marrow, and more specifically somewhere at or before the common myeloid progenitor cell, because both of the platelets and the RBCs are low, as well our reticulocyte count is low, and that tells us that the RBCs aren't being replenished as well as they should be. Now this question is very direct, it gives you the information without a big case to digest or 200 unnecessary facts, but that's exactly the beauty of these crude questions. This is an amount of information you should really take out of a 2-paragraph question, and they give you a lot of unnecessary facts, and you pick out the important points. So if a question stem is very complicated, and these are all the points I get out of it, well, there may only be one answer that deals with the bone marrow. At the very least, you'll be able to eliminate several wrong answer choices that are possibly peripheral or don't involve the bone marrow, and you'll have a few answers to pick from. At the very least, you'll have a better shot at the right one that way. Now we're going to talk about the leukocytes, or white blood cells, which are cells from hematopoiesis that are a part of the immune system and help fight infection. Normal concentrations of leukocytes are 4 to 10,000 per microliter, and there are two main classes of leukocytes. First, the granulocytes. All of these cells continue on our myeloid lineage and derive directly from the myeloblast. These cells also contain many granules and have lobed nuclei. These include neutrophils, eosinophils, and basophils. Next, the mononuclear cells. First, these include the monocytes, again derived from the myeloid lineage, and, like the granulocytes, is derived directly from the myeloblast. Second, the lymphoid cells. These we will discuss momentarily. Lymphoid cells derive from the lymphoid progenitor cell that we see here. Here we look at the normal range for a white blood cell count differential, and from most to least common, it is neutrophils at 54 to 62%, lymphocytes at 25 to 33%, monocytes at 3 to 7%, eosinophils at 1 to 3%, and basophils at 0 to 0.75%. Many people use the mnemonic, neutrophils like making everything better, to remember this order from most to least common. And I'm really not sure why, but one mnemonic that's always stuck with me is, never let monkeys eat bananas. It's just funny. Either way you go about memorizing the normal differential count, it's very important that you at least have an idea of what percent of the total WBC count each type should be. This is because in your questions you'll be given a differential of WBCs, and they'll expect you to know which cells are abnormally high and low and why, but we'll be getting into why in just a moment. The neutrophils and the lymphocytes are the most important to know specific ranges for, but you find other pathologic examples that are commonly tested like eosinophilia, and again we'll be discussing this guy in a minute. So let's talk a little more in depth about each of these various types of leukocytes. Neutrophils are derived from the myeloblast and are the most common type of leukocyte, making up 54 to 62% of WBCs. They are found in the blood and tissues and take part in the acute inflammatory response. Do you remember from pathology which of the two major classes of immunity the acute inflammatory response falls under? That's the innate immune system. You may recall the mechanism of this acute inflammatory response from when we spoke about how leukocytes leave the bloodstream and enter tissues. This might be a good time to go back and review your adhesion molecules. Neutrophils are sometimes referred to as polymorphonuclear cells, or PMNs, because they are characterized by multilobular nuclei. Also, neutrophils characteristically have large, spherical, azurophilic, or bluish granules filled with hydrolytic enzymes. Here we can see an example of several neutrophils. You can see multiple stages of maturity in this photo, and you'll notice that the mature PMNs on the left have 2 to 5 lobes in their nuclei, while this neutrophil on the right has a continuous C-shaped nucleus. This neutrophil is what's known as a band neutrophil, and is a neutrophil that is not yet fully mature. If you have an abnormally high amount of band cells, you would call that a bandemia, and it would indicate, maybe, an infection like a bacteremia. What does all that really mean? Basically, this means that more of your neutrophils are very young, which means that for some reason your body is adding neutrophils at a very fast rate, likely because it needs to fight an infection like bacteria in your bloodstream. Now here is a picture you will commonly see in your board exams. This is also a neutrophil, but what is abnormal about this PMN? Well, what if the question sim said the patient were a person who had been practicing strict veganism for many years, and this CBC given has a low hemoglobin and hematocrit? Then this would be a case of vitamin B12 deficiency anemia. Vegans commonly lack a natural source of vitamin B12 and require supplementation. Both folate and B12 deficiency cause a characteristic hypersegmentation of PMNs where you see 6 or more lobes in the nucleus as you do here. This is a highly testable topic and will appear on many of your exams. We'll be seeing more of this in our discussion of anemias. Monocytes are again derived from the myeloblast of myeloid lineage, and they make up 2 to 10% of leukocytes. The monocyte is a large cell and has a large unilobular or kidney-shaped nucleus with frosted glass cytoplasm. The classic nucleus is presented well here in this drawing. When monocytes leave the bloodstream and enter the tissues, they differentiate into macrophages and dendritic cells. Macrophages are descendants from the circulating blood monocytes that we just talked about and take on the name macrophage once they've entered the tissues. The name macrophage comes from the roots macro, meaning big, and phage, meaning eater, so they eat, or phagocytize, bacteria and other bad guys, cell debris, old red blood cells, damaged cells, and other tissues in their role as part of the innate immune system. Damaged tissues, or T helper cells, will release chemokines that attract monocytes to the site. Once on site, the monocytes will morph into macrophages, and they can remain there for a long time. T helper cells will release interferon gamma to activate the macrophages, and macrophages will in turn release TNF alpha to induce and maintain granuloma formations. Remember granulomatous diseases from pathology? Well, it's these cells and their TNF alpha that are your main actors in the granulomatous diseases. Diseases like TB and sarcoidosis are big hitter test topics, and this granuloma formation involving interferon gamma and TNF alpha is a common pathway that can be applied to test questions in all of your granulomatous diseases. Here we see a macrophage that has phagocytized several yeast cells as it does its job. As well as just eating bad guys, macrophages can present phagocytized antigens on MHC class II receptors that we learned about in our immunology lectures to trigger the adaptive immune response. This dual role in both innate and adaptive immune systems is a relatively distinct feature of macrophages. One important cell marker that can be both stained for and used to quantify macrophages is the surface CD14 molecule. This is one of many CD, or cluster of differentiation, surface markers that we'll talk about, particularly when we discuss the B and T lymphocytes. It is important to know these markers because they will either be given to you in the stem of a question, or all of your answer choices will be CD markers. You'll have to know both what cell the test is referring to and the marker for which that cell is known.